So now let's get started with today's clinical topic. And our speaker today is my friend, Dr. Tim Kosinski. He is a highly sought after speaker and teacher in the world of implant dentistry. He's taught hundreds of courses, he's written dozens of articles, and he's been a mentor to many dentists as they enter the world of implant dentistry. He's also the editor of General Dentistry, which is the official journal of the AGD. And our topic today is grafting, and Tim is going to go over some cases step by step from the very basic all the way to the more complex. Tim, it's great to have you back, and it is all yours.
All right, let me share my screen. Hopefully everybody can see that perfectly now.
Perfect.
And we'll begin. As always, thank you for the invitation, Dr. Park and Nicole and the whole team at Glidewell. Yeah, we do a lot of programs. And before I begin, I'm going to say go Tigers. I have my Detroit Tiger tie on. We're very proud of our baseball team. Hope that doesn't offend anybody nationally. But very, very important. Implant dentistry is a very important part of my practice, as Dr. Park mentioned. But it's equally important to be able to set the foundation for implant dentistry. Placing or drilling a hole in bone is not the hardest thing that we do in the procedure. Obviously, we have to diagnose and plan and understand anatomy and things like that. But the actual drilling is not that hard. But preparing the site is very important. With all the issues going on in the world today, setting a foundation for your house will ensure a long-term success. So bone grafting is a very, very important part of my practice. And what I was asked to do today was just to go through some of the clinical cases that we do routinely in our practice, from very simple procedures that I think all of you listening should be able to provide, to some of the more complex things that we do to provide a great service to our patients. This is beautiful northern Michigan. And drkosinski.com is an education website, has my articles and a lot of YouTube videos of some of the things that we're going to show you today. So that'll be a good reference for future information. So what are our objectives today? I know I speak quickly. We have a lot of information to cover. But we're going to talk about atraumatic extractions. And many of you have heard me before. It's a term that I coined probably 10 years ago. Took a lot of hits for that. When I talk about atraumatic extractions, we're talking about minimally traumatic. Minimally traumatic to the patient, giving the patient a positive experience. Atraumatic, minimally traumatic to the bone. Bone is gold to me. The more hard tissue we can maintain, the better the end result. But we can also show you how to grow bone. I can teach you to grow bone basically 100% of the time. And I know that's a very bold statement for this dentist from Detroit to say, but when we have a socket or we have a facial wall missing, we can grow bone predictably today with the techniques that we're going to briefly demonstrate today. But equally important, atraumatic or minimally traumatic to you, the practitioner. It's imperative that we save our body, our hands, our muscles, our back, our eyes. We're going to review the protocols for socket grafting and facial wall defects, specifically those two situations. Understanding the grafting principles for immediate implant placement. That's important. If we have a site that we anesthetize the patient, we numb the patient, we remove a tooth, we're able to immediately place an implant, which eliminates the additional healing time for grafting to occur, but also allows the patient to go through one surgical procedure as opposed to many. And there's certain rules that we have to follow to implement that. We'll talk about ridge splitting. We do a lot of ridge splitting to maintain bone. We'll talk briefly about platelet-rich fibrin, how we achieve that. I have some videos today to accelerate hard tissue healing. PRF is a wonderful treatment. I don't do it routinely throughout my practice, but when it's necessary, it doesn't give us a better result. It gives us a faster result. And then we'll talk about sinus tenting, and I'll even demonstrate a Caldwell-Luc technique, which isn't magic, maybe something that the practitioners need to get additional training. But I want to introduce you to these techniques that we routinely do in our practice to provide a stable foundation for successful implants. and what we're able to accomplish. So we all know this. I'm going to do this really quickly. If we lose bone, we get loss of bone height, we get loss of bone width, right? We take a tooth out, bone is going to shrink down and in the lower jaw, up and in the upper jaw. We know that the posterior maxillary sinus area will collapse. How much? We don't know. So it's imperative that you communicate with your patients on the importance of bone grafting. If we do not graft, we do not know how that hard tissue is going to respond over time. And if we do not graft and we get significant bone loss, then the patient may not be a candidate for future implants without a much more invasive surgical procedure, taking bone from the chin or from the ramus area to build bone up. For those of you in the audience today, I don't know your experiences, obviously, but our concern is always the posterior maxilla and the posterior mandible, right? We're concerned about the sinus, and we're concerned about the position of the mandibular canal or the mandibular nerve. So giving yourself the advantage of setting a foundation is critical. Dental implants is the most financially rewarding thing you can do in your practice, by far. You're going to collect insurance on your extractions. You're going to charge a nominal fee for your grafting. You're setting a foundation for the most financially rewarding thing you can do in dentistry today. With continual bone loss, we can end up with paresthesia or even fracturing and collapse of the face. Grafting at the time of extraction will help minimize bone loss, supports the soft tissue, helps prevent periodontal pathology. And the literature is clear that we can provide an adequate site for implants in a very short 3 to 4 month period. And we can objectively determine the integration of a graft radiographically with our digital radiographs. If we don't graft, soft tissue will infiltrate that socket. Epithelium grows 10 times faster than bone. We know that bone heals from the apex towards the crest, takes time. Epithelium goes from the crest towards the apex, and it's a race. Tissue will always win. We will get loss of ridge height and width. And the literature says that we get 30 to 60% bone loss in a very short 3 year period. So these are important things that you must address with your patients. For those patients that go, oh, I don't want that, I don't want to pay that, I don't want to invest in a grafting procedure. It's important that you communicate the benefits of what you're able to provide. Socket grafting failures. Many of you know this, what we've covered so far in the first couple of minutes, but we've gone back and tried to place an implant and we get mush. We don't have predictability. Well, suturing is very important. If you're using an allograft material, human bone, you must protect that allograft from invagination of epithelium. So we must protect it with a membrane. I'm going to show you, I'll demonstrate those techniques that we use. That membrane must be placed passively, and it must extend at least 2 millimeters beyond any defect, and it must remain intact for at least 6 weeks. You need to use high quality materials. I use Newport Biologics from Glidewell. I have great successes with it. I have basically 2 grafts and 1 membrane in my practice, and 1 type of suture with different needles and thicknesses of the suture material itself. If the membrane is dislodged or comes out before 6 weeks, the case becomes unpredictable. It may work, it may not. So we'll demonstrate that. And again, when we extract a tooth, there's reasons why we extract a tooth. There may be infection, and it's imperative that we curette, we clean out any granulation. Purple blood is bad. Granulation is bad. I won't immediately place an implant in an infected site, but I will graft. So you have to feel comfortable cleaning out that site, eliminating or decontaminate the site completely. The resorbable membrane, I use no non-resorbable membranes in my practice. I use a high quality 3 to 4 month, Newport Biologic membrane. It resorbs in 3 to 4 months. It's purified intact collagen from porcine peritoneum. It's very easy to manipulate and reposition. And again, positioning is critical in use of a membrane. So I don't inventory a lot of things in my office. And, Dr. Park knows we do 80 to 100 implants a month in my practice. So we are constantly extracting teeth and preparing sites for future implants. The mineralized allograft that I use is a blend. It's a cortical and cancellous particulate. It is osteoconductive and allows very, very good integration in a very short amount of time, and I can objectively determine the bone turnover radiographically. So again, these materials are from Newport Biologics. You can talk to Glidewell Direct to get these products. So it's a 250 to 1,000 micron human bone, very, very high quality. The other material, the other graft material that I use is a synthetic. I'll refer to it as a synthetic material. It's called Osteogen, again, purchased through Glidewell Direct. It's calcium apatite in a bovine Achilles tendon matrix. It is a synthetic material made in a laboratory. So if you have any patients that are having a hard time wanting human bone or an animal bone, this is an excellent material. It's also very, very inexpensive, and it doesn't need a membrane. The material is such that I don't have to protect it from invagination of epithelium. The epithelium will follow the path of least resistance and grow over the top of the material. So these two grafts, Newport Biologic allograft material and a synthetic Osteogen plug, again from Newport Biologics. Platelet-rich fibrin is in the literature a lot. It's autologous platelets and leukocytes are present in a complex fibrin matrix. It accelerates healing of soft and hard tissue. It doesn't make better healing, it's just faster healing. And you're going to draw blood, venous blood, and you're going to spin it. I'm not going to spend a lot of time on this. There's different companies that you can get this information from, but it releases biologically active proteins, platelet alpha factors, platelet-rich bone, and morphogenic proteins. Again, this is from the patient's body. You're going to get a faster bone response. And let's just go run through a quick video in high speed. So what we do is we tourniquet the patient and we will draw blood. Now you can have a staff member do this. Most community colleges will have phlebotomy classes. It's usually a half a day or a day. There's nothing magical here, but we will draw blood in precise tubes. It's very, very quick. I work very fast in my office, as you can see. And we will draw as many vials as we need. And again, I don't do this routine with all my patients because it takes time, but in certain situations, it is recommended. We will then spin the blood. I'll be doing my surgery as this is spinning, and we will create a fibrin material that we can use to mix in our allograft material. We can make what's called sticky bone, or we can use it as a membrane itself. Here we'll compress the clot that is formulated through spinning. And again, this has all the bone morphogenic proteins that stimulate bone and tissue health. And again, platelet-rich plasma can also be achieved. Again, that has the growth factors present, which allows us to elevate our grafting procedures or stimulate the bone turnover. We all understand that osteoclasts invade the area, osteoblasts lay down new bone, and it is a process. We then mix our sticky bone with our wetted allograft material from Newport Biologics, our 250 to 1,000 microns. And you can see we can use this as a membrane, or we can cut it up. Here we have a tooth that's deemed non-restorable. We're going to extract it, clean out our socket sites, maintaining our sockets. We have all our walls intact. We will curette the site, curette, remove any granulation. Purple blood is bad, red blood is good. And here I took my allograft material with chopped up platelet-rich fibrin, making what's called sticky bone. And we will go back to this site in about a month, 4 weeks, and I can successfully place a dental implant. I took my platelet-rich fibrin, and that is now my membrane, which will prevent epithelium from growing over the top. I'm using my Vicryl sutures from Newport Biologics. Closing the site, I do not need primary closure here. That is not important. Epithelium will grow a 0.5 millimeter to 1 millimeter a day. I will see this patient in a week to remove the sutures, and we will get bone turnover in a very, very short amount of time. So hopefully that was helpful. In today's program, we're going to talk about two defects. A 5-wall defect where all the walls are intact, the floor is intact, or a 4-wall defect where the facial wall is missing. Anything more than that, I'm not going to demonstrate here today. I think that's a much more intensive description of bone grafting that we should save for another day. So let's go through some clinical cases. We have a tooth that's deemed non-restorable, and we are going to remove it. Now, most of us remove a crown. I'm assuming you'll take some type of burr and section on the facial, onto the occlusal, onto the lingual here, take some type of instrument and elevate. The mesial section usually comes off, and then you have to get the distal section off. Here I'm using what's referred to as a WAM key. You may, WAMKEY. I will simply make a window, an elliptical window in the facial aspect of this crown. In the occlusal third, I'm assuming that the preparation is at least 2 millimeters apically. And I'm then taking this specially designed stainless steel instrument with a ball. There's 3 of them, small, medium, and large. And I can simply remove that crown in a matter of seconds. Now, if I weren't removing this tooth, I could use this crown as my temporary restoration while you're fabricating the final new crown. But here I'm going to remove the tooth. In mandibular molar teeth, if there's divergent roots, I normally like to section it. So I'm taking a 557 long surgical burr, and I'm sectioning to the furcation area. I want to make sure that I completely cut through. So I'll take a radiograph, I'll elevate, loosen it a little bit, and then I can remove these mesial and distal roots as if they were single rooted bicuspid teeth. And I'm not going to take a lot of time with this, but many of you are aware that I love the physics forceps, if you can Google it, from Gold-Dent, Gold-Dent. And it's a series of 3 instruments, upper right, upper anterior, upper left, and lower universal. It has 2 components. The beak is a shovel-shaped edge, which will engage the lingual surface of the root, 1 to 3 millimeters subgingival. The bumper will be placed down the vestibule as far as possible. It's simply a center of rotation. And I can simply, with 2 fingers, atraumatically remove this root. So the patients are not feeling the proprioception. I'm simply rotating my wrist. That tooth will pop, and I'm able to remove the tooth roots in total. I always take a radiograph following an extraction. I want to make sure that there's no root tips left in place. And here I've taken my osteogen material, very inexpensive material, $40 or $50, that does not require a membrane. It's calcium apatite in a bovine Achilles tendon matrix. I cut it in half, and it has a little bit of substance to it, almost like styrofoam. I can cut it in half, and I'm simply placing it into the sockets to the crest or slightly above the crest firmly. I'm not crushing it, to the apex, and I'm taking an immediate radiograph. Now you can see there's still radiolucency there, but how is bone going to turn over? It's going to turn over from the apex towards the crest. Epithelium goes from the crest towards the apex. Epithelium will not be able to grow into this material as it would with a particulate allograft material. So I don't need a membrane, and I don't need primary closure. We will suture the area. I'm respecting the band of attached gingiva on the facial aspect. Epithelium will grow a 0.5 millimeter to 1 millimeter a day. In a short 3-month period, here we did a CBCT analysis, and I'm looking at my sagittal view of the site that I'd like to place an implant. Now remember, our initial stability with any implant system is in the apical 2 millimeters. bone turnover occurs from the apex towards the crest. So even though I don't have complete maturity in the coronal 2/3 of this site, I do have bone turnover in the apical third, which will allow me to have implant stability. And we'll run through a quick video here. I'll run through this relatively quickly, but this is 3 months post-extraction grafting. I'm going to infiltrate. There's no reason for me to block this. Bone is not innervated at this time. The only thing the patient could possibly feel is the tissue, the epithelium. So I'm simply infiltrating and walking up the surgical site, blanching the tissue. And I'm going to make a reflection here to be able to demonstrate what we're going to see. We have to respect the band of attached gingiva. Here I've taken an Orban knife, O-R-B-A-N knife. It's a stainless steel blade that will allow me to make what I refer to as an envelope reflection. I make no vertical incisions here. If you do not incise into mucosal tissue, you will not have postoperative discomfort or minimal postoperative discomfort. You will not get swelling or pain because we don't get prostaglandin and histamine release. So I'm making an envelope and I want you to see what I see. Bone turnover. It may not be completely mature. Here I'm using the HT implant protocol. We're taking a pilot burr, which is a small diameter burr to make my initial penetration through the cortical plate. And you can see I'm working a little bit hard here. Taking a 2.4 pilot burr to create my mesial distal buccal lingual direction. I will use the apices, the adjacent teeth, radiographically to determine my width. This is a very safe surgical procedure. I'm using anatomy and CBCT diagnosis. Here's my 3.0 HT diameter burr, and you can see there's one line there. It's very, very easy surgical procedure. You can harvest that viable bone from those sites if you prefer. I'm widening the osteotomy here with a 3.5 diameter burr, resting it to the widest portion of that osteotomy burr, and we're harvesting really good bone, a 4.3 diameter. And you can see how efficient the HT surgical system is. This is real time. It's really a matter of minutes to be able to provide a patient a single implant retained prosthesis. Here's our 5.0. This is our final burr. And I'm taking my implant, a 5.0 by 10 diameter HT implant, slowing down the motor to 25 RPMs. Simply threading that implant into position. Neil, I'm going to run through this a little bit quicker. And we're going to torque it to position. If I'm able to achieve 25 Newton centimeters of torque, I'm then able to put what we refer to as a healing abutment, which is a taller screw, eliminating the need for secondary surgery. 1 week post-op. And we're able to, in 3 months, remove that healing abutment. I will scan with the materials from Glidewell. We have a Medit scanner. We will scan that implant. We're respecting a band of attached gingiva. And the team at Glidewell will fabricate the final screw retained implant prosthesis. Cover it over with Teflon tape, a cotton pellet, and composite restoration. We're able to provide this service very efficiently, cost effectively, and providing the service that the patients are requiring in your practices today. Postoperative radiograph and postoperative CBCT. Let's talk about sinus tenting. And again, we have some videos, and I want to go go through this information. We're afraid of the sinus, and we can predictably lift the sinus floor 3 millimeters and immediately place an implant. But I want my implants to be 70% in viable natural bone. We can lift the sinus floor by tenting up to 6 millimeters. This is not something that you need to be afraid of. You need to respect. So here I reflected my site with my envelope reflection. I'm doing my osteotomy as we've demonstrated, short of the sinus floor. And then I'm going to use an osteotome. I know people are going to ask me about the different techniques, and there's a lot of them, but we can simply use the osteotome using the HT implant osteome system, which mimics the implant itself. And what we're doing here is we're widening that medullary bone, which is relatively soft, and we're lifting that floor of the sinus. We're lifting that floor, lifting that Schneiderian membrane. And it's a pretty simple procedure. We'll keep looking at this radiographically, know your position. And here I took an osteogen plug, and I'm simply placing it into my osteotomy site, using the osteotome to kind of use that as my new floor. It'll also increase the stability, the initial stability of our dental implant as we place it. And we're just torquing that implant into position with our torque wrench to the crest. And what's amazing, in that soft medullary bone, we were able to torque the HT implant to 45 Newton centimeters. That's amazing torque using this system. We can put our cover screw or healing abutment. Our implant is in position. We take a CBCT. You can see that we lifted that floor very predictably. So not magic, doctors, something that is something that you should train yourself and get very good at. Now, what about a situation like this where we really have no bone to work with, 2 or 3 millimeters? What we'll do is referred to as a Caldwell-Luc or a lateral window procedure. And again, we will make our reflection so that we can see the viable bone. I'm not incising into mucosa. I'm staying in attached gingiva. I'm going to simply use a piezo. I would not use a high-speed handpiece here. A piezo, which is an oscillating burr, which only affects hard tissue. It does not affect soft tissue. So I'm making I guess the best way to describe it, it would be a dishwasher door, where I'm going to lift that window occlusally, and that window is going to become my new floor. So it's a process where I'm just taking the material. Now here, I love using the osteogen material, which has some substance to it, like styrofoam, and I'm using that to lift and push that floor, but push that Schneiderian membrane. Here I've taken a second piece, and then I'm going to take my allograft, my Newport Biologic allograft, and create my new wall. When we do that, I will then use a membrane to cover that area, protect it, and simply suture the area. I'll bring that patient back in a week to remove the sutures, and you can see the incredible amount of vertical bone that we were able to achieve. From basically nothing, we will allow this site to heal for about 6 months, 4 months here, and reevaluate the site. You're going to get some shrinkage, but we now have over 10 millimeters of height and 10 millimeters of width. These now become routine implant sites. I'll reflect again, and I want you to see what we see. Bone. I'm placing my implants per the HT surgical technique. I suture again, and I'll wait another 4 months for this to heal. We get excellent tissue response. And here we fabricated splinted implant retained crowns. Again, doctors, this is not magic. You may need some more experience doing this. hands-on courses that are provided through the Resnick programs and through Glidewell, but this is something we can train you. I don't want you to be afraid of these procedures, at least be aware that they exist. Ridge splitting is another important process when we have bone loss. This was just a wonderful patient, and I'm going to run through this relatively quickly to respect everybody's time. But we have a site that was edentulous for many, many years. And sometimes I'll do what we call sequential therapy. I will leave teeth that we will remove in the future for a flipper type of appliance as opposed to putting the patient in a denture. This is not a good situation for the all-on X protocol because we really need to get initial torque and stability with implants if we're going to load them immediately. So we're atraumatically removing teeth using my physics forceps. And I'm going to make my reflection. And I want to demonstrate how thin this anterior maxillary bone is. It's a challenging situation for us. But we do have techniques. I'm going to flatten that ridge, remove any spicules. And I'm going to use the piezo to make a trough, that will allow me to maintain that facial and palatal bone and be able to place my HT implant and spread that trough, maintaining the facial plate, creating great initial stability. Now, remember, this is an oscillating burr. It only works on hard tissue, similar to the instrument used to cut a cast off. Making my trough. And again, these videos are on YouTube or drkosinski.com. So we're able to maintain 1 millimeter, 2 millimeters of facial plate and palatal bone, widening it. I'm making my little refrigerator door. I'm using that socket to place my HT implant. And then all the defects, the trough is then grafted with our Newport Biologics allograft material. And again, using PRF, this is a great indication for creating our fibrin clots, and that's my new membrane. So I'm going to expect really fast healing in this site. Placing my implants, the patient wore the flipper using those 2 teeth to support it. We were able to evaluate the site, maintain a facial wall. Here we did a digital impression 4 months post-operatively. Smile composers or PMMAs with the team at Glidewell. On seating, I'll remove those 2 teeth, and the team at Glidewell, our Alicia, fabricated a beautiful Bruxer zirconia full arch restoration. This patient's maintained this for probably 5 years now, very successfully. So there are a lot of options out there for you in treating your patients that you need to be aware of. Guided implant surgery obviously is all the rage today. And this is a gentleman that he was the manager of a car dealership when I bought my new truck. And what do you do, Doc? I'm a dentist. God, I hate my smile. I hate my teeth. And he's in the public eye all the time.
Getting ready for a pretty major surgery. Going to give you a new smile. I just want to kind of find out, are you nervous? Are you excited?
Very excited. I hate my smile. You know, I just want to have it's like a new step in life.
Are you confident in Dr. Kosinski?
Yes. Listen, I saw another doctor prior to him about 5 years ago, and he scared me so bad. It's taking me this long to move forward with it.
Awesome.
And I think that there was just God's will for the doctor here.
So, very, very important here. We interviewed the patient ahead of time. Communication is very critical in your successful implant practice. Having empathy towards your patients, trying to meet their expectations takes time. That's the hard part of dentistry. Visualize the case finish before you start. And I'd like to say, early in my career, I had great mentors, but it took me 10 years to master that. in today's environment with the technology that we have, the support that you have, CBCT analysis, our diagnosis, we can virtually design, place our implants, and restore prior to any surgical intervention. It is a great time to be a dentist. It's a great time to be an implant dentist. Just get your training and understand the process from start to finish. And I'm so proud to see his pictures on Facebook. He's just thrilled. This is in with our consultants this morning. This is success. These are the patients that will send their family and friends. A happy patient, patient that you treated atraumatically, will refer many, many patients, and that's the key to our success. So just see before and after. So, we're removing the teeth. The team at Glidewell helps us to determine, to diagnose and plan our implant placement. They give us all the information that we need to predictably design these cases. Now, guided surgery is a great tool. It's not a panacea, but it is a tool. When we're working with competent team members at Glidewell, it's going to help you to really maximize the end result for your patients. Takes a lot of the fear factor out of it. Now, in my cases, my all-on cases, I always have a denture in place, just in case. And this is, just a digital denture, because you have to get initial torque with your implants to be able to load them immediately. So I have no problems, as long as you communicate ahead of time, not loading my cases immediately, but rather allowing those implants to heal unimposed, unimpeded, for a short period of time. It's the end result that matters. So the team at Glidewell fabricated a guide over the teeth that allows me to create my stabilization pins. We then extract teeth atraumatically, minimally traumatically. Bone is gold to us, doctors. It is gold. So we're removing the teeth quite predictably with not a lot of pressure in a matter of minutes. We're removing the teeth. Then I'm going to make my reflection. And this is the toughest part, because these are pretty serious reflections. We have to remove diseased bone. And very, very importantly, I'm going to slow down for a little bit, Dr. Park. You need help with these with trained diagnosticians and the team at Glidewell, because when we're doing the zirconia or Bruxer implant retained prostheses, our full arch screw retained implant retained prostheses, we must have 14 to 16 millimeters of interocclusal space per arch. So we have to remove some of this diseased bone to create that. If you are not doing that, then you're going to have problems restoring these cases, and that can be a real serious detriment. So in your cases that you're doing, please work with competent team members to maximize the result. Visualize the entire case finish before you ever start. You have technology that will allow you to do this. We then have a reduction guide. The stabilizing pins go into that preset position, and I have to remove this diseased bone and create that 14 to 16 millimeters of interocclusal space in the maxillary arch. So we'll simply remove that excess tissue. We then have a guided surgery appliance that will fit onto that. And then the surgical procedure becomes pretty routine. We'll use the HT guided surgical kit, which incorporates not only the length of the implant that we predetermined, but the soft tissue, the thickness of the surgical guide itself. Becomes a very, very simple, easy process using the HT system. We will drill to the hub. We can harvest that autogenous bone. That's great bone. We're preparing to the hub. We then have our implants in position. We torque them to position. We will then repair all the defected areas, the extraction sockets, the facial plate missing. And you can see I did not get torque in the posterior implants. I then spun blood, created my PR platelet-rich plasma and my platelet-rich fibrin. I then grafted with our Newport biologic graft. I cut it in pieces, made sticky bone, used the remaining PRF as my membrane, sutured the site, seated a denture, which fit perfectly because it's all digitally designed preoperatively. 1 week post-op with PRF. It's just amazing, amazing healing. I removed the sutures. I would allow 4 months for healing, and then we just did our standard impression, whether you're scanning or we're developing new techniques daily. These are multi-unit abutments that allow, we're working with a high-quality lab with Glidewell. They understand the processes. Our access holes are going to be palatal or on the occlusal surface. These are jigs. I don't want to go through a lot of this process, but everything has to be passively placed, and the team at Glidewell has perfected this site. We do a final impression. We then do a wax try-in. We do provisionals. We can evaluate the sites, what the patient likes, what the patient doesn't like. Too white, showing too much gum, not enough gum. These access holes are ideal, and we can fabricate the final Bruxer implant retained prosthesis. Patient can enjoy life, have their ribs, improve their quality of life dramatically. And he sent this picture for his anniversary. So I know I covered things really, really quickly, but I think it's imperative that we understand what you're able to accomplish. Now we need to take you to the next step, slow down, and show you these processes on models. Hopefully we'll see you at one of the symposiums where we can really get to know each other. And Neil, I know, Dr. Park, I know I went a little bit over there, and I know you have me going to another lecture, so happy to answer any questions that may occur.
That's great. You got a few minutes before you have to run over and do
I
another
have
lecture.
all the time in the world.
Okay, so let's do a few of these. Can you delineate when you're for socket grafting, when is the osteogen plug appropriate, and when do you go ahead and do allograft with a collagen membrane?
Great question. So let me back up a little bit. You take a tooth out, we understand that. You all know how to do that, hopefully. And you understand now the importance of grafting, okay, to prevent horizontal and vertical bone loss, especially in the posterior mandible, posterior maxilla. So the patients go, well, I don't want to pay for that because dental insurance doesn't cover grafting for GPs, or most of them don't. And so now you have a financial issue. So as I said, it's very, very important, Dr. Park, that we educate the patients why this is important. It's very important. So if we have all walls intact, all the walls are intact, I would use the osteogen plug because it's a 40-minute graft product. And it takes minutes, and I don't need a membrane. If my facial wall is missing greater than 5 millimeters, I will use an allograft material and a membrane. And that membrane, as I mentioned, we didn't really demonstrate it, needs to be positioned 2 millimeters beyond the defect. So you have to make a pretty extensive reflection. You have to see the defect. You're also investing $110 in allograft and $110 in a membrane. So your costs are much more expensive. So if I have all walls intact, I will use osteogen. If the facial defect is 5 millimeters or less, I'll use osteogen. If the defect is extensive on the facial wall, I will place a membrane passively beyond the defect and use allograft. That's pretty much my rule of thumb.
Makes sense. That's a really good protocol to follow. Here's a doctor that has extracted number 7, did bone grafting with a membrane, and eventually is going to put an implant in that spot. How long do we have to wait before we can put a provisional, like a partial, over that during the healing process? Can we do that right after surgery?
Oh yeah, I'll do that right away. I'll either have a flipper, as long as it's not pressing on the site. Or I will do an Essex. We do a lot of Essex, snap-on smiles, snap-its that the team at Glidewell can fabricate for you. There's a lot of options that you have. Obviously, the patient's not going to want to walk around. You can bond a tooth if they have
Right.
natural teeth
Right.
there. So there's a lot of options. I'm not, as you know, Dr. Parr, I'm not an immediate load guy. I'm not judging. I've done over 19,000 implants, and I know the problems that I've had with my protocol. And so I'm never in a big hurry. It's the end result that matters for me. So, and remember, radiographically, bone is going to heal from the apex towards the crest. Our initial stability with our implant is in the apical 2 millimeters. So I don't need complete bone turnover before I do my osteotomy. I just need initial stability.
Got it. Got it. Okay. What about antibiotics? Do you routinely prescribe antibiotics for extraction and graft, pre-op, post-op? What's your plan?
Yeah, I'm not a big antibiotic user. I know the white paper with the American Academy of Implant Dentistry is very clear. We don't need antibiotics if there's no infection, okay? But if there's infection, I will prescribe routinely amoxicillin 3 times a day for 3 days. I don't carry my antibiotic a long time. If I can start the day before, that's fine. But many of our patients come in as an emergency situation. So if I'm extracting a tooth, that's pretty much my routine. Amoxicillin, 500 milligrams, 3 times a day for 3 days. If they're allergic, then a Z-Pak. Pretty routinely. I rarely give a narcotic. As long as you're not incising into mucosal tissue, 600 milligrams, ibuprofen, PRN pain. Patients just don't experience a lot of discomfort with most of our surgical procedures today.
Yep. Yep. Here's a good one. Okay, so we've got a patient that doesn't want bovine or porcine grafting because of religious reasons, and also doesn't want allograft. Are there any pure synthetics out there that are worth using?
Even our osteogen is calcium apatite, which is the building block of human bone, in a bovine Achilles tendon matrix. Okay, a bovine Achilles tendon matrix. So there is bovine in it. Again, being in Detroit, we have a lot of ethnic groups. You have to be honest with patients. You have to tell them what you're putting in their body. That hasn't been an issue. I use the term synthetic. Human bone is a different story. We will get some pushback on human bone, but I haven't really gotten pushback on the osteogen. There's
Right.
collagen plugs, but again, they're all animal products. So
Right. Yeah, I mean, I've offered patients the opportunity. Well, we can do an autograft, so we can take another part of your jaw and use that as the source, and that usually makes them way more friendly to allograft once you explain that.
Or
So,
or do PRF. I mean, you could draw blood. I mean, that's a process. It takes time,
right.
and how valuable time is in my practice.
Exactly. Here's a good question. What's the procedure if you have a small sinus perforation during extraction? Can you go ahead and graft, or do you go ahead and need to heal that first?
Great question. Don't be afraid of a small perforation in the sinus. The body is an amazing thing. It will heal. Okay. I would use, if it's small, you could use a little osteogen plug, put it in there. Don't push it up in there. You could use a resorbable membrane. Again, I use a 3 to 4 month Newport Biologics, and just make a little circle, like a little parachute, and kind of place it, and then put your graft material in that. Okay. We can lift the Schneiderian membrane 3 millimeters very, very predictably. Small perforations are easy to deal with, but don't make it bigger. But post-operative is very important. Tell them that they have a perforation there, so they may have a little bloody nose. They could, not to panic. I don't want them blowing their nose. If they get a little stuffy on that side of the sinus, go to CVS, Target, get some nasal spray. There's literally 30 there. I don't care which one. Do not blow their nose heavily. Sleep with an extra pillow tonight.
Very good. Very good. And you mentioned getting some more training. Can you tell us some opportunities? Are you teaching any courses that come up? What's going on?
We do. Yeah. If you go to the Glidewell site, we're in Newport, we're in Newport Beach, we're in New Jersey, we're in Louisville. We've been in Seattle. So there's lots of programs, and the mentors at Glidewell, they're all excellent,
Yeah.
excellent practitioners.
I
So,
mean, in November, we've got our implant symposium. You're doing a workshop. I mean, there's lots of great opportunities for learning there. So yes, I agree with you. I think hitting our website would be a great place to start.
yep, yep.
So Dr. Kosinski, my friend, thank you so much for another outstanding lecture. You really put together something different and really addressed the needs out there, and we've gotten great response. So I thank you very much. We look forward to having you back here. And good luck with that other lecture today. And thanks everyone for joining us. Thanks to our panel. And join us next week when we'll have another great implant expert. Dr. Shankar Iyer will be here to talk about sinus augmentations, particularly the lateral approach. So be sure to join us. Thanks, Tim. Thanks, everybody. And we'll see you next week. Take care.
Go Tigers.
Bye-bye. Go Tigers. Go Padres.